I begin in the name of Almighty God, who is most gracious and merciful. Good morning, afternoon, or evening, wherever you are in the globe. Greetings and salams to all. I feel extremely honored and privileged to welcome you all as the president of DFoot International to this Global Meat Awareness Week program for year 2024, where all the region get together under one roof. DFoot International would also like to thank especially to our sponsor Urgo for continuous support. Thank you very much. Today we have two renowned speakers for this event, and I will introduce you as we go along the program. So first of all, we'll play a short video about 2 to 3 minutes, a message on Awareness Week 2024 and DFoot International. Okay, can we have a short video, please?
It is an honor and privilege to address you today as President of DFoot International. I speak not only to the diverse and vibrant individual present here today, but also to hearts and minds of millions worldwide, united by a common cause to combat diabetes-related food complications. DFoot International is an organization consists of people working in the field of diabetes-related food complications. These people are spread across 7 regions in the world: Sub-Saharan Africa, South and Central America, Middle East and North Africa, North America and Caribbean, Europe, Southeast Asia, and Western Pacific, all dedicated to providing preventive food care for people with diabetes through awareness, education, and professional guidance. The looming global diabetes epidemic is a step reality, projected to rise with the highest burden in low middle income countries. As diabetes rates surge, so does the incidence of diabetes related complications, including food related complications, which is our focus of action here at DFoot International. Our mission of DFoot International is resolved and clear: ending avoidable low-limb amputation due to diabetes worldwide. It is not just a vision, but a mandate, a call to action demanding our utmost attention and urgency. We should all unify our goal and aim for a 50% reduction in limb amputation rates by 2026. In this mighty ambition, education and the empowerment of healthcare profession are our only weapons of choice. As I often say and will continue to say, education is only powerful tool we have. Education is power, especially in the low middle income countries, where it is free and immensely effective when properly implemented. It is noble pursuit. We at DFoot International are proud to see the happenings of Diabetic Awareness Week campaign. This campaign, we find each one of you as a faithful ally in this great endeavor. The success of DFoot International goals depends on your patience and efforts for educating communities and obviously raising awareness. Diabetes Awareness Week campaign is one of the flagship program of DFoot International. As every year, this year we'll have programs in all the regions starting from 7 to 14 November. We have one day allocated for global meet where all the regions come together on one platform. Today, I invite every one of you to picture a world where every healthcare professional is prepared to offer knowledge and skills to provide specialized food care. Imagine a nation where stigma attached to preventable amputation is eliminated and a gap between affordable and accessible diabetes food treatment is permanently addressed. Coming closer to the end of my short introduction, DFoot International extends a hand of collaboration to every one of you. Let us work together to promote care of diabetes-related food complications and their management, making it financially feasible and increase awareness about it. Lastly, I would like to personally thank everyone present here today for being part of this noble cause. We look forward to the impact we can create together. Thank you so much. Thank you.
Thank you, Zaima. So now I will introduce the first speaker. I'm going to introduce the first speaker. That's He actually doesn't need any introductions. He is a well-known person, Professor Andrew Boulton. We feel extremely honored and privileged to introduce the first speaker for his Global Awareness Week for this year, 2024. Professor Andrew Boulton is consultant physician and a professor of medicine, University of Manchester. He's a visiting professor at University of Miami, Florida, consultant physician, Manchester, Royal Infancy. President Worldwide Initiatives of Diabetes Education, Chair of Eurodial, Alliance for European Diabetes Research. He was the immediate past President of IDF, past President of European Association for Study of Diabetes. He developed a clinical research and clinical service for diabetic complications, particularly neuropathy and nephropathy, such that the unit is now #1 worldwide for output publications in diabetic neuropathy and foot disease. He was a founding chair of Diabetic Food Study Group for European Association for the Study of Diabetes in 1998, and I also remember it was in Barcelona, Spain. Previously editor of Diabetes Medicine, Journal of British Diabetic Association, and currently associated editor of Diabetes Care, formerly chair of postgraduate education. He has authored more than 550 peer-reviewed manuscripts with an index of more than 130 and many book chapters, and he has even written a book mainly on diabetes, lower limb, and renal complication. Coming to the awards, among his many awards, he has received ADA Rogers Picor Lectureship, ESD Camillo Gogli Prize, first recipient of International Award on Diabetic Food Research. He's a winner of American Diabetic Association Harold Rifkin Award for Distinguished International Service in Diabetes in 2002. He received Georgetown Distinguished Achievement Award in 2012 in diabetic limb salvage, that's in USA, Washington. In 2015, he visited Japan and gave a prize lecture on diabetic complications at the Japan Society of Diabetes. In 2017, he was a Banting Memorial Lecturer at Diabetes UK. In 2017, he also received an International Diabetes Endocrinologist Award for the Year of American Association of Clinical Endocrinologists. And in 2019, he has been ranked #1 UK researcher in complication field of, and there are many, but these are the main things So we feel extremely honored and privileged to welcome our speaker, Professor Andrew Boulton, for the Global Meat Awareness Week 2024, and his topic today is a lifetime experience in the field of diabetes-related food complication and global progress, a journey of 5 decades. Professor Boulton, when he recorded this talk, he was in America attending the conference. It's very privileged and nice that he honored us giving his talk. And at the moment, he is flying to Doha to attend the conference tomorrow. So he told me that if there is any burning questions, then we can email him or WhatsApp him. Well, email, everybody has it, or we WhatsApp him, then he can reply. Otherwise, if it is need arise. So he's accessible even on the above 35,000 sea, 35,000 above the sea level. So let's play his video. Thank you very much.
Well, good morning. I'm actually in Phoenix, Arizona at the Desert Foot meeting, and I'm sorry I cannot be with you on the day of your meeting to give this live. But it's a great honor for me to be invited to give this lecture and to be with, at least virtually, many friends and colleagues from across the world. Now, you know the title of my talk, and this is really my lifetime history. A 45-year-old journey. Actually, I'm older than 45, by the way. A 45-year-old journey from leprosy to smart technology in the diabetic foot. But I'm going to go back to Nottingham in my school days, where I went to Nottingham High School. My whole family was in English literature. I was a sort of dropout. My father was professor of English at Nottingham, where D.H. Lawrence had also been to the same school. And he was from Nottingham, and he was the famous author of books such as Women in Love, Sons and Lovers, and the famous Lady Chatterley's Lover. Now, he had been to the same school. Nottingham High School. But it was actually another Lawrence that I got to know better, not in person because he died back in 1968, but he was one of the first people in England to receive insulin. He was training to be a surgeon at King's College Hospital back in 1922, and he developed thirst and polyuria and knew he had type 1 diabetes. And in those pre-insulin days, that was really a death certificate. So he thought, oh, I'm going to go to somewhere nice. I've got a year or two to live. And he went on the famous Allen diet, lost a lot of weight, and went to work as a general practitioner in Florence in Italy, which I'm sure you will agree, especially our Italian friends there, is actually a very beautiful city. And he was working there and had all sorts of problems when he was very high blood sugars because of lack of insulin, of course, including painful neuropathy, which I'll return to. When he got a telegram in 1923, come back quickly to London. We have this new drug called insulin. It seems to work. And he wrote in his diary, this is probably quackery. But he went back anyway and became the first person to be one of the first to be treated with insulin successfully in the UK, and changed his mind from being a surgeon, very wisely, of course, and became a diabetologist and was the senior diabetologist at King's College Hospital in London for many years and lived until 1968. And I actually gave the R.D. Lawrence lecture many years ago, 1990. So back to my life history. After Nottingham, I went to medical school in Newcastle upon Tyne in the northeast of England. And it was well known for neurology. And I became very interested in neurology in many ways due to the excellent senior professor of neurology, Professor Boulton, later Sir John Boulton, and lastly, Lord Boulton, for the years until he died. He's in his 90s, just a few years ago. He was warden of an Oxford college, but he was an excellent neurologist, a great clinician who focused really on clinical science and examination and the importance of taking a good history. And every week, he would have a seminar in a large room, and he would bring in a patient who he had been asked to see with a difficult case. And it was full of medical students, junior doctors, senior doctors, and even his consultant colleagues who would attend this session. And Walton would be presented this case that we hadn't seen before, and he would take a history, an examination, and then would come to the diagnosis, which was invariably correct. Now, on this occasion, the patient, who was often international, had only come locally from County Durham, just to the south of Newcastle. And also during this presentation, everybody was sitting and listening very carefully because he would pick on people from the audience and ask them to do history or a brief exam. And the more senior you were, the more difficult this got. Well, the first person he called upon that day to examine something on this patient was me. He said, Boulton, I want you to examine this patient's fundi, and gave me an ophthalmoscope. So I did indeed look in the fundi, and this is what I saw. And this, of course, is optic atrophy. I said, as you would in those days, not like medical students today, but I said, sir, this patient has optic neuropathy. Well, he said, yes, he does have optic neuropathy, but Boulton, you looked, but you didn't see everything. Medical students, you see, told me need to look and see. Now, you had some difficulty examining the fundi. Why is that? Because you missed the fact he has a pendular nystagmus, which is equal phases of the eyes moving across. So nystagmus is the flicking movement of the eye. And he deliberately left his shirt open so you could see his chest. You didn't notice that on his chest, he had what we call coal tattoos. And these were black marks in skin creases that were really very common in miners who were coal miners working underground. And he said, well, if you'd have seen everything, you got the most important thing, he had optic atrophy, but you missed that he had nystagmus. And the clue came because if he had nystagmus and you look at the chest, he's got coal tar, whatever they call them, tattoos, coal tattoos. He said this chap must have been working for many years as a miner, working as a miner underground, and miners in those days started in their teens. He was in a very dim lighting for most of the day. So he couldn't focus, hence the pendular nystagmus. So I was very impressed by this. And of course, the case went on. And I'm pleased to say that other people make serious errors as well. I don't think my error was too serious, but I learned a lot from that. Well, then I moved to Sheffield after my intern jobs, or house jobs as we used to call them, and worked in Sheffield and was doing a registrarship in neurology, first of all at the Royal Infirmary, which is now an old people's home, and then the Hallamshire Hospital. But I came across as a registrar Professor John Ward, who many of you will remember died just before the pandemic. And he was very interested in diabetes complications, particularly neuropathy. And what he emphasized was learn by observing, again, just like Boulton, good history and exam. And he said, do not try to do too many studies, identify one or two research questions. And he said that clinical research grows out of being a busy clinician. And of course, he was right. So back to R.D. Lawrence, as I said to you, he was one of the first people to receive insulin. And I gave the R.D. Lawrence lectures, as I said. But before that, I read his notes. And I was most interested that when he was in Florence with terribly high blood sugars, fluctuating from high to very high, he wrote this: I don't like peripheral neuritis. It interferes with my work. It's uncomfortable. So that led me to think perhaps that the pain of neuropathy is something to do with very high blood sugars or fluctuating blood sugars. And that's his quote there, 1923, I don't like peripheral neuritis. It interferes with work. So in my early days in Sheffield as a research registrar, I was contemplating what causes neuropathic pain. And the most interesting here is neuroma properties. So we know that diabetic neuropathy is a dying back neuropathy. The nerves die back, so the longest nerves are affected, such as in the feet and legs. But there's also attempts at regeneration. And regenerating nerve fibers fire messages, ectopic impulse generation. And these messages in C and A delta fibers are pain interpreted as most uncomfortable pain that reflected often in the area where that nerve used to supply. So what causes neuropathic pain? So it's probably this, plus perhaps glycemic flux, blood glucose swinging from high to low. So one of my earliest published studies in 1982 was we looked at a number of patients with painful neuropathy and put them onto very early continuous subcutaneous insulin infusion, not the modern stuff today with CGM, closed loop, etc. This was using a syringe driver with a subcutaneous connection. And we were able to look at 4 months of near normal glycemia, continuous subcutaneous insulin infusion. In those days, it was not Nova Rapid, whatever it was called before that. I can't remember. So something like Nova Rapid, but not a human. And 4 months of near normal glycemia, the pain score actually fell from 7, which is the graphic rating scale maximum 10, to 2. And this is associated with, as best we could measure it, with regular glucose finger prick tests from a baseline of 85, that's very high fluctuation, down to 26. So we thought that stable normoglycemia might be important in the genesis of neuropathic pain. So 20 years later in Manchester, I was able to actually confirm this in a study we published in Diabetic Medicine in 2002, because at that time they'd just started the rather old-fashioned now continuous glucose monitors, the Medtronic one. And so we were able to look at glucose excursions in painful and painless neuropathy. So we took type 1 diabetic patients with, all of them had a dense peripheral neuropathy, but half had pain and the other half were painless. And we wore the Minimed, now Medtronic. They wore the continuous glucose sensor for 3 days. And those with painful symptoms kept a regular visual analog scale of their pain. And we were able to measure, like we did in the first study, fluctuations from the mean. Now, that's the old-fashioned mini-med. And today we have the very fancy, for example, the Libras, Freestyle Libra on the upper arm, but this was much more complicated, of course. But it still did continuous glucose tissue monitoring, and we were able to measure very regular tissue blood glucose or tissue glucose levels. And this is a profile of someone with painless neuropathy, no symptoms at all. And you see the overall control is not brilliant. 10 is 180 milligrams percent if you're used to that, and 5 is 90. These are the blood glucose, capillary blood glucose, which really correlate brilliantly with the continuous tissue measurements here. But you see here, this is relatively stable control. What we saw in those with painful neuropathy was this kind of profile all over the place. Overall control worse, and again, higher levels and more fluctuation. And the results of this study were that in the painful group, the overall control was worse in millimoles. This is, that's around the average was just over 200 milligrams percent. Many more hyperglycemic values compared with the painless group. And the M value, which is a special measure of excursion from the mean, was twice as high in those with painful as those with painless. And the median numbers of glycemic excursions of more than 0.5 or 9 milligrams percent was again higher. So we felt that patients with painful symptoms have poorer diabetes control, higher mean blood glucose readings, and greater blood glucose flux. Well, back in 1983, I went as a young visiting assistant professor to the University of Miami for 2 years, working with my good friend, Jay Schuyler, who many of you will know. And the importance of history and examination came home again. Because in 1983, I was doing one of my clinics when this interesting patient came in. And eventually, we wrote him up in the British Medical Journal in 1984. And this is entitled Diabetic Thoracic Polyradiculopathy Presenting as an Abdominal Swelling, as you can see here. Now, this guy's history was that he had been to his primary care physician in North, and he said, I've woken up with this strange bulge in my side. And the GP looked at him and he said, yes, you have got a bulge in your side, so thought it might be a hernia, sent him to a surgeon. And the surgeon looked at him and very carefully he said, I don't know what this is. I don't think it is a hernia, but I'll get you into hospital for a few days and we'll do a few tests. So he had barium studies at both ends, as you did in those days, 40 years ago. Some primitive scans that were available in those days, and the surgeon said, I can't find the cause. So he sent him then to a gastroenterologist, then to a urologist. So he had intravenous pyelogram, as it was then called as well. So he had all these tests. And then the surgeon said, oh, look, this guy's got diabetes. Perhaps we'll ask someone with diabetes to see him. So he was sent to see me. I mean, he wasn't done well. He didn't really need to be in hospital. So he came as a new patient to me in my outpatient clinic in Miami in 1983. So I sat down and actually took a history. And I said to him, okay, you say you woke up with a bulge in your side, which I can see, but just tell me, did you have any strange feeling or symptoms in any part of your body? Because I know you have diabetes, and you had no neuropathic symptoms in the past. He said, yes, actually, the night before I woke up with this, I couldn't sleep very well because it was a very strange pain in that area too, especially if I sort of turned over or brushed my skin against the bedclothes. So the penny dropped then. So I thought to him, okay, that sounds like a neuropathic pain. And can you describe it? He said, very difficult to describe. It's sort of like a burning, or the skin was on fire. Always very difficult to describe neuropathic symptoms. So then I examined him, and he had absent abdominal reflex in the lower part of the abdomen here, and hyperesthesia and allodynia in this region here, and the sort of C6, 7, 8, 9 region. So I thought this is a thoracic polyradicular neuropathy that actually presented as an abdominal swelling rather than the usual neuropathic pain in the abdominal wall. So one test I did, it had thousands of dollars of tests, and heaven knows how it costs even in those days to stay in hospital for a few days. One test, an EMG, and this gave the diagnosis. He had fibrillations and abnormalities in the thoracic muscles in these dermatomes, or this area, sort of T6 to T10. And the diagnosis was a diabetic thoracic radiculoneuropathy. I can hardly pronounce it myself. It's because of the dry climate here in Phoenix, I think. So he had this thoracic polyradiculoneuropathy, and I gave him some simple painkillers, and I said, look, this should get better within 6 months. So 6 months later, he came back to me, he said, Doc, you're brilliant. The pain's gone and the swelling's gone. I said, I'm not brilliant at all. I didn't do anything for you. Just gave you some aspirin. I said, this is the natural history of the condition, and there's no specific treatment, and it got better. So that was very important. Taking a history and a good clinical examination could have saved the healthcare system there many thousands of dollars, which, of course, next week, I'm pre-recording this just before the election. Heaven knows who'll be in power, but it all depends who is, how much it costs. So whilst in Miami, I'd previously been interested in necrobiosis, which I saw quite a lot in Sheffield with John Ward. I noticed that it occurred generally in young type 1 diabetic females, not in type 2, as the literature suggested, but in type 1, who had other complications. And we also noticed there was reduced sensation in the lesions. So it was well known to be a rare dermatologic complication of diabetes with a prevalence of 0.3%, 10 times more common in women. And the old literature said, and this is a big study here many years ago, also occurs in non-diabetic individuals, but if you really press them, you can find an abnormal GTT. Well, I thought, let's do a study while we're in Miami, because there's a very good dermatology division. They were interested in this as well. And this is what necrobiosis looks like here. These sort of very, usually painless, but it can be painful at times. They can ulcerate. And this is a healing ulcer here. And you can see all these telangiectasia and this sunken with a raised edge. This is the classic and a sort of yellowish, lipid-like looking view, or what it looked like anyway. So you can see this slight concavity here. Here's a better example. You can see this concavity here, and this is the same patient with a different view. So this is necrobiosis lipoidica diabeticorum. So as we were seeing it frequently, as we had a large population of type 1 diabetic patients, and we saw 15 cases and 10 previously, so 25 patients in this study. And we published this, necrobiosis lipoidica, a clinico-pathologic study, and this was published in the Journal of the American Academy of Dermatology in 1988, and it's probably the first and the last paper I have to say I'll ever publish in that journal. So what we did was, many of these did have ulcers. Here's an ulcerative case, as you see here. So what we did was, why don't we look at some biopsies, of course with IRB permission, biopsies, and look at what's going on here and the explanation to see why there's reduced sensation. And what we showed here, here's the biopsy across, this is the lesion here, and this is the perinormal skin. And you can see the first thing here, here's the lesion. In the perinormal skin, there's gross inflammation with necrobiotic fronds of tissue here. So it appears that the necrobiosis actually moves underneath the perinormal skin, which has an important message for if you're going to give intralesional steroids, they're probably best given around the edge. But the second thing we found when we did S100, let's go back one, S100 protein, which is a cutaneous nerve identifier, and this is a normal skin biopsy here, and this brownish discoloration, especially here, is S100 protein. So these are cutaneous nerves. But in an active lesion of necrobiosis, this had changed. There's hardly any staining for S100 protein. So we thought, what's happening here is the necrobiotic inflammatory tissue is destroying superficial nerves, which explains the loss of sensation in the lesion. So this could be a very good sign for necrobiosis. It could be pathognomonic. If you can't decide if it's necrobiosis or not, it's the loss of feeling in the lesion. So this is the summary slide here. It's most commonly seen in type 1. Most of these patients had other microvascular complications. Necrobiotic fronds are most active under the perilesional skin, and that necrobiotic tissue destroys superficial nerves, and this loss of sensation in the lesion can be pathognomonic of the condition. So that was the importance of clinical history and clinical examination. And then came my first visit to India, where I spoke at a congress with the Indian Congress. I can't remember what the building was called, but it was a research area in a beautiful park in the south of Madras, now Chennai. Here it is, the proceedings to the International Conference on Biomechanics and Clinical Kinesiology of Hand and Foot in Diabetes and Leprosy. And this was in the Indian Institute of Technology, which was in that nice park. Most important of that whole meeting was that I met Dr. Paul Brand. Now, many of you have heard of him. Some of you may have known him, but I was a great honor that I knew him from 1985 until he died 8 years later. This is a very historic picture taken at one of Larry Harkness's meetings in San Antonio, probably in the late 1980s. And this is Wagner, and that's not the composer. That's Wagner, F.W. Wagner, who described, along with Meggitt, the classification system, the first one, in the University of Rancho Los Amigos, Los Angeles. Well, that's F.W. Wagner. And this is the late Roger Pecoraro, who sadly died very young and worked, of course, with Dale Reiber, the epidemiologist, and has a prize of the ADA named after him each year. This is Lee Sanders. He was the first podiatrist ever to be president of the American Diabetes Association. Many of you will know Larry Harkness, a great character and sort of father of podiatry in America. And here's Dr. Paul Brand, and I'll say more about him. And by the way, the person on the left here is actually me nearly 40 years ago. It shows you the dangers of working in the diabetic foot. Probably a good thing you can't see me today, by the way. And he had worked in Vellore, the CMC in Vellore, and in Karigiri, where he worked. And this is pictures from South Tamil Nadu, the beautiful grounds of this hospital in Karigiri. And of course, we saw terrible sights when I first visited there. Young people with loss of limb, intractable ulcers, scarring, deformity. And this is people with leprosy, of course. And the typical view, this is a few years later when I visited, just driving from Madras down to Vellore, the typical oxen cart. And these people are all walking barefoot. And when I saw people walking barefoot, and some of them had a foot drop, they almost certainly had leprosy. So what did Dr. Paul Brand tell us? Well, he told us a lot. First of all, as did Sir John Walton, my mentor, the importance of clinical observation. And he rightly stated that any patient with a plantar ulcer who walks into the clinic without a limp must have neuropathy. And that's true. Very important clinical sign. And he described as pain as God's greatest gift to mankind, which you only realize is a gift when you lose that gift, and leads to all the problems we see in diabetic patients with foot problems and, of course, leprosy. This is a leprosy patient in Madras I spoke to many years ago, and he cited this patient. I shall never be free until I can feel pain, as he came back with a recurrent ulcer. Then he moved to the rather splendid area on the grounds on the banks of the Mississippi River in South Louisiana, known as Carville. Carville was the National Hansen's Disease Center in the United States. And I had the pleasure of lecturing on some courses that Dr. Brand worked there. A very splendid place. And anybody with leprosy until the late 1960s, were moved there and given a house, and they spent the rest of their lives there. So it's a very interesting place to actually visit, to lecture, and speak to people with leprosy. And Brand said to me, when I started seeing diabetic ulcers, it reminded me of leprosy ulcers. He said, these are not diabetic or leprosy ulcers, these are trophic ulcers. And of course, he was right again. And he said, in diabetes and leprosy, it is not the disease itself, but neural damage caused by it that results in ulcers. Well, I moved in 1986 as a consultant to Manchester Royal Infirmary, which didn't quite look like this then. This is an older picture, and today it's looking a bit different. I'm not sure which one I prefer, by the way. The older one was a very handsome building, which I was working in until they demolished it and built this thing. And one of my first fellows was Aristides Vevis, who's now a professor at Harvard. And Paul Brand said to me, I'm sure that it was loss of feeling, but he was very keen that I did a study, as we spoke a lot, to look at what caused neuropathy and prove it was neuropathy. So we did an observational prospective study soon after I came to Manchester, started back in 1988. We measured vibration perception to assess neuropathy, and we recorded all foot ulcers. Using the biesthesiometer, many of you will be familiar with this, and the reading is from 0 to 50. The higher the reading, then the more significant the loss of vibration perception, large fiber function. And what we showed here, the total number of ulcers, if you just look at this line here, the risk per patient per year, those with no basic neuropathy, BPT less than 15, 0.7%, less than 1% risk. And these are first ulcers. None of these patients had a history of ulcers. But if your BPT was more than 25, it was sevenfold and increased up to 1 in 20 or 5%. So then, we think about temperature monitoring and all the smart technology we use today, but most of it was described by Paul Brand, pressure relief. He did some very early foot pressure measurements and looked at the contribution of footwear to ulcers, and he had a very early development of pressure sensing devices to warn of high pressures. So he had some very primitive sensors and showed that pressures were high under the metatarsal heads of the diabetic foot, and published this 60 years ago. So we were able to take this further with a sophisticated, in 1980s, firstly in Sheffield, then in Manchester, a sophisticated machine, optical petabarograph, and we were able to demonstrate, working with Matthew Young and Aris Bevis, that high foot pressures are associated with first and recurrent ulcers, and that high foot pressures predict ulcers in the neuropathic foot. This is a series of publications from these studies, first in Sheffield and later in Manchester. Well then, to take a slight aside, I was associate editor of Diabetic Medicine with Philip Home, some of you may know, and I got a call one evening at home, and this is the first issue here in 1984. So I got a call, I think it was about 1990 at home, and it was Sir John Nabarro on the phone, who was then chairman of Diabetes UK, or British Diabetic Association as it then was. And he said, "Is that you, Boulton?" I said, "Yes." "Sir John Nabarro here." He said, "Philip Holmes said you've been very helpful with Diabetic Medicine as the senior associate editor. So we'd like you to be the next editor. So don't rush, think about it. I'll call you back in half an hour." And indeed, he did call me back in half an hour. So I took on this and was that for the next few years. And then at the end of that time, Professor Michael Berger in Düsseldorf, who's another very strong character. Some of you may have heard of him. He tragically died young of a retroperitoneal tumor. But he was really a very decisive person. And when I was finishing my editorship of Diabetic Medicine, 1994, he said, "Andrew," he said, we'd love you to be the next chair of postgraduate education on the Executive Committee of European Association for the Study of Diabetes. So I took that job on, and I was worked at that one for 6 years as chair of PG, postgraduate education for EASD. And we hosted a number of courses. First of all, my first job was to really take educational courses on basically diagnosis, prevention, and management of diabetes and its complications, bringing experts from all over Europe. Firstly, I was responsible mainly for the former Warsaw Pact and Soviet countries in Europe, and we did courses all over that region. But after that, I was asked to take on the new task of the international education. We did courses all over the world. This is one of the first courses we did in Kaunas in Lithuania, because my wife and colleague, Professor Loretta Vilikite, is originally from there. So having those connections was very important. The first course we did there was actually before 2005. This is one of the later ones. And we have a number of well-known people lecturing at this meeting, including there's Ben Lipsky, David Armstrong somewhere on the picture, Roy Freeman, and people from all over the world. And there's Lee Sanders again, you see there, and David Sachs from National Institutes of Health. And we had local speakers, and we put on postgraduate education, not only for Lithuania, but for the Baltic countries as a whole. And we brought people in from other neighboring countries, such as Poland, and in those days, White Russia or Belarus. One of the early postgraduate courses we did internationally was in Panama. We had a very large turnout here, and again, we brought in well-known international speakers. Here's a later one in Vietnam, which was an interesting one in 2008, and later in China, and there's one in 10 years ago in Baku in Azerbaijan. So I became president of EASD, and during my presidency, EASD celebrated 50 years of progress from its founding in 1965. And the EASD has come a long way. And of course, we were so lucky to be able to put on one of the first important cardiovascular endpoint studies for the drugs that had to be done by FDA rule. And this was the EMPA-REG Symposium. One of my last tasks as president in 2015 was to introduce this symposium in Stockholm at the EASD meeting, that 50th year anniversary. And this had a huge audience. And it's the first time I've ever heard of spontaneous clapping during a presentation, which is what occurred. Of course, since then, we've had many more interesting studies with GLP-1s as well, and also the SGLT2 inhibitors. That was the team in Düsseldorf that ran the EASD in my last year of presidency. And there's Victor Jorgens, who many of you will remember, who was the executive director. Returning to India, I was fortunate a few years ago, or more than 10 years ago, I think, to share the stage with Sri Narendra Modi, the Prime Minister of India. And this was a most interesting meeting. And in his speech, he said, the biggest threat to our survival in India is no longer infectious diseases like leprosy, malaria, tuberculosis, HIV. It's non-communicable diseases like diabetes. So I said to him at the end, you're quite correct, sir, on that one. And I think they're taking diabetes very seriously, and his government is. But I also became involved in South America, and I'm jumping around the world a bit now. And this is, of course, South America, and the biggest country is Brazil. And in Brazil, I was involved with Linda Pedrosa, who you all know, a very good friend, and she did some training with me in the early 1990s. I flew out to Brazil to help implement the diabetic foot clinics across Brazil. This is the first one in the capital, Brasilia. And then here we are to 2001, 34, another 10 in actually implementation. And then by 2007, there's a large number of foot clinics. So this was a very enjoyable and productive collaboration in helping to secure good foot care in India. And of course, the step-by-step programs, which my good friend Abbas and Vijay and all the people who are listening today know very much more about than I do, has become so important in that region. I know Linda has been a leader in the South American region. It's difficult to give exact data from the effect of starting these clinics, but this is just looking at the Brasilia Center here. And from starting the foot clinic, you can see the actual females and males, a generalized trend to reduction of major amputation over the 8 years since it started. Then I was involved in Asia. I told you about Vietnam. But our very good friend Shigeo Kono from Kyoto, and this is a famous temple here in Kyoto. He did so much work in the Western Pacific region of IDF, International Diabetes Federation, and these are some of the foot ulcers he saw on his travels around countries which are major problems in countries, especially I think just Cambodia and places like that. And he would run a course every year. It would bring diabetologists and expertise and neurologists and infectious diseases. One of these has Ben Lipsky on it, and these continued for many years and are just finished because I think Shigeo has actually taken retirement now. I'm sure he's still active. So this is activity in that region. And then lastly, of course, we mustn't forget, for many reasons, Sub-Saharan Africa. Looking at the IDF Atlas, and I was president of International Diabetes Federation until the end of 2021, from 2019. So it was a 3-year I did. And what happened here is that the biggest, we put an atlas out, as you know, the last one was 2021. Actually, I think I finished in 2022. That was the extra year I did because of the pandemic. So what is happening in the world is that the biggest increase in the prevalence of diabetes in the next decade is likely to be seen in sub-Saharan Africa. So this is such an important area. And of course, Abbas led an article that I was on looking at diabetic foot problems published in FRCP a couple of 2 or 3 years ago on foot problems in sub-Saharan Africa. And it was a pleasure to be there. Again, this is 10 years ago. There's my good friend Abbas who's introduced this meeting today with myself. And I think this was the Minister of Health talking about the importance of diabetic foot problems and the Pan-African Diabetic Foot Study Group, which was then being founded by Abbas and others. So coming back to the last section, what's happening in terms of new technology? And of course, what we're seeing now is smart technologies being involved in diabetic foot ulcer prevention. Thermography, again, it was Brand 50 years ago who said that the diabetic foot warms up before it breaks down. And of course, he was right. And continuous plantar pressure monitoring, 60 years ago, Brand had talked about the importance of pressure. So we now have smart technology. And this is a smart thermographic bath mat, if you like, and the patient stands on this and it's read centrally. And this is one of my good friend Bob Freiberg's paper. And again, you can have continuous plantar pressure monitoring and have a picture here with Bijan Najafi, one of his studies. So it's see it, save it. Simple things can help. This is the pressure stat, which is a more advanced type of Harris mat. Now, the Harris mat was used, of course, a lot in India and leprosy, but you tend to get a lot of ink on your fingers. This is much cleaner, and you can give this to the patient, and it just shows the pattern of high pressures. The darker the area, the higher the pressure. The patient can pin this on their bathroom wall to remind them this is the area they should look at each day. So seeing is believing. This is one of the other, excuse me, I've been giving too many lectures here, I can tell, but it's early morning. So this is the temp stat, which is can measure temperatures just by standing on it. and a more modern version actually can directly give the patient a picture of their own foot. And we have smart socks as well. And this is Siren Healthcare won the success at the Consumer Electronics Show. They won the prize for the most innovative development. And these were smart socks that can measure pressure and temperature, run by Dr. Rand Ma, who used to work with David Armstrong. And this here, it shows from Siren Care, obviously a high-risk foot. Medical students will look at this and miss that there's a toe missing, but I think you all can see that. And here you can measure the temperature, and if it gets warmer and stays warm, then you can do something about it. So, of course, Bob Freiberg did one of the early studies with the Podometrics device, and this was 132 patients he followed for 34 weeks, published in Diabetes Care 7 years ago. And daily foot pressures were measured remotely, but they weren't fed back to the patient because this was just an observational study to see if high temperatures predicted foot ulcers. Well, these were high-risk patients with a past history. Plantar temperature asymmetries were analyzed, and over 1 in 4 had foot ulcer episodes, and nearly 100% of these were correctly predicted using a 2.2 degrees continued asymmetry for a day or two between the active foot and the other foot. So now ongoing studies, of course, are happening, randomized controlled trials. Here's a study I was involved in, my good friend and collaborator, Professor Neil Reeves, and Caroline Abbott, who's worked with me for many years, you probably know. And this is a novel plantar pressure sensing smart insoles, not temperature, this is pressure. You can wear during normal gait, and it can help warn you if there's a problem. So we know high foot pressures contributed to foot ulcers, where pressure is a laboratory measure, but can we give pressure feedback using smart insoles? And we can. And this were put inside the shoe, and the patient had a wristwatch that didn't actually tell the time, but would vibrate if one foot was high foot pressure, abnormally high, or both feet pressure. You look at the wristwatch, it would tell you which area was too high, and the patient could either alter their gait or rest, stop walking until it was settled. Well, the results were quite convincing. The recurrent ulcer rate was reduced by 71%. And this is, of course, pressure offloading plus patient empowerment. Most important, the patient had something they could interact with, and if they told them that something was wrong, they could act on that themselves. So, to finish with COVID, mortality in those of COVID-19, as you all know, was much more common in people with diabetes. They were older, male, poor glycemic control, hypertension, and cardiovascular disease. But look, isn't this the same as risk for foot ulcers? Older, male, poor glycemic control, hypertension, and other diabetes complications. So COVID pandemic was a nightmare for diabetes because of people dying in my hospital. I think it was 1 in 3 or 1 in 4 had diabetes. So what happened? At the first lockdown in March 2021, my hospital suspended all routine lab tests unless there were actual acute emergencies, suspension of all routine investigations, including x-rays and MRIs, other than an emergency, and non-invasive vascular tests unless an emergency. So we were back to the sort of 1960s, but I kept my clinics going, and I moved all patients with foot problems from the hospital to an off-site clinic because patients were frightened to come to the hospital. People knew that people with COVID were likely to be in the hospital, and diabetes plus COVID is bad, and if I go to the hospital, I've got greater risk. We published this paper, A Tale of Two Cities, Saving the Diabetic Foot During COVID, with my former PhD student, David Armstrong, as you all know him, and his colleague Laura Shinn and Frank Bowling and myself in Manchester. We had compared 2 diabetic foot services. A Tale of Two Cities was not the Dickensian Paris and London, but it was slightly different, Manchester and Los Angeles. And we looked at the caseload, compared 6 weeks pre and post weeks lockdown, changes in care and outcomes. And we saw huge changes. Pre-lockdown, we were seeing 373 patients a week at our diabetic foot clinics. Post-lockdown, it was down, but we're still seeing a lot. Telecare nil, 78, but really you can't do much on telecare for diabetic foot care if you've got an ulcer. Home visits, we do, and we had a huge number of home visits. Our podiatrists went out to visit patients at home. Hospitalization was down. And the changes were not dissimilar in Los Angeles. Of course, they had much more telemedicine. They don't do home domiciliary visits. Let me give you a couple of cases from our report. The first is a patient of mine who was a 73-year-old male, type 2 diabetes, known to have neuropathy and ischemic heart disease. He presented 3 weeks prior to lockdown with extensive ulcer in the interphalangeal joint right hallux. Good pulses, Doppler signals normal, probe to bone was positive. And this is a distension, a sausage shaped, if you like, distension of the toe, and this lesion at probe to bone. Clinically, that's going to be osteomyelitis. But fortunately, he presented about 3 days before the lockdown. So our clinical suspicions were confirmed on this X-ray. You can see gross destruction here, and the septic arthritis in the IP joint here. So he was treated with clindamycin and ciprofloxacin for 8 weeks, and it healed up completely. And I was able to do an X-ray about 2 months later when they sort of relaxed some of the very severe restrictions. That'd be about 6 months after the COVID pandemic began. We showed radiologic healing. Here's another one of mine, again from Manchester. He presented in week 1 of lockdown, the grossly swollen second toe. Again, pulse is absent, Doppler signal, monophasic, posterior tibial was okay, and torsalis pedis was not. Positive probe to bone show test and sausage-shaped toe, and here it is. I think you would agree this is a sausage-shaped distension of the toe, and the ulcer, you can see here, it probes straight through. He was treated in a similar manner, and we were able to heal that up as well, and showed radiologic healing. I'm not going to show David's cases because he had some very interesting cases too, but they were mainly surgical. So I'm going to leave you at the end of this talk with 1 or 2 thoughts. And Professor Lindsay, you've heard me use this before, was Professor of Medicine at the University of Belfast about 100 years ago. He wrote and taught his medical students to learn these aphorisms. For 1 mistake made for not knowing, 10 mistakes are made for not looking. Always look at the feet of people with diabetes whenever you see them with shoes and socks removed. So, I'm not going to go on to that. I'm going to stick to this. And the multidisciplinary team is important. Diabetic foot care. And this is in order of alphabet, not of importance. And the multidisciplinary team might contain these individuals. Some may include physical medicine, psychologists, etc. But I think the key people here are the patient, of course, the podiatrist, and the pedorthist or orthotist. Shoes are a major cause of diabetes in Western countries. The primary care physician needs to know what they're looking for and when to refer. The diabetologist may be the least important, interventional radiologist, and good clinical musculoskeletal radiologists as well, diabetes nurse educators, and so on. So, what's the success? What's the necessary qualities needed for success? And I would suggest to you, from my experience, that first of all, having good organizational skills is very important in doing research. Secondly, is listening, not only to your patients, but also to your team, to your trainees who may have come up with a very bright idea, to your other members of the team. We are a bit like communism, all people are equal. I won't say that some are more equal than others, but all people are equal in my team. We listen. So if the podiatrist is worried about something, we listen. Diplomacy, that's very important. We're not seeing too much of that at the moment where I am now. There's nothing on the TV apart from the big election coming up, which the result of which will be known when you listen to me today. There's nothing else on the TV. So diplomacy is lacking there, but diplomacy is very important. Team building, building up a team of people who are reliable and well organized. Patience, nothing occurs overnight. And then prioritization, get your priorities right. And a willingness to collaborate, ability to delegate. Some people like to be a sort of a master of all trades, and want to be in charge of everything. But no, you can't do that. Be willing to delegate to people who are good in that particular field. And a strong team spirit. Most of all is luck. I mean, if you look at my career, I happened to go to Newcastle, I happened to get interested in neurology, and I happened to go to Sheffield, I happened to meet Don Ward, who had a job coming. It's all chance. I wasn't planning to go into diabetes. I don't know what I was planning to do, to be quite honest. And probably genes help. I mean, there's nobody in my family who is a medic at all. The closest I can get to is my grandfather, who is an undertaker, but we won't talk about that. So genes are very important. And what I probably learned from my father and gained from my father and inherited was how to give a lecture. I've never had any training. And also how to use slides with quotations, which really brings people to focus on something before you move on to the next session. And of course, a lot of good luck and the right genes. You can't do much about either of those. So let's leave you with this Chinese proverb. Superior doctors prevent the disease. Mediocre doctors treat the disease before it is evident. Inferior doctors treat the full-blown disease. Sadly, all too common, we're working as inferior doctors. But screening for complications, screening for foot problems, screening for early changes to prevent the evidence of ulcer to occur is very important. But if you can prevent the disease, there are now chances to prevent diabetes, as we know from modern lectures and papers recently. And this is an important saying by Edward Wilson: you teach me and I forget. You show me and I remember. You involve me and I understand. So the important thing, because we know that if you educate patients with a very severe neuropathy with a history of ulcers, that's not enough. They need to be involved in their care, and smart technologies making this possible. So let's hope that is useful. And one of Gandhi's favorite quotations was, "He who strives never perishes." So keep striving, keep going, and get to the end if you can. So with that, I will thank you very much for your attention. I hope you have a very good meeting. And I'm sorry I can't be there in person because I'll be in Doha.
Very much, Andrew, and thank you for honoring us and giving this lecture in such a tight schedule of yours. Thank you very much. So we go to now live presentations by Dr. Chris Manu. So we have Dr. Chris Manu. We extremely honored and privileged to introduce second speaker for this Global Meat Awareness Week. And this talk has been sponsored, and this program whole has been sponsored by OGO. So Chris is a consultant diabetologist and general medicine at King's College Hospital. He has been involved in several services improvements projects within the Southeast London, as well as setting up a new food care pathways. He has developed research interest in diabetes-related peripheral arterial disease, and he's also undertaken a postdoctorate degree on vascular risk stratification of people with diabetes and food complications. He has been a proactive in setting up and running of the Southeast London Multidiscipline Diabetes Food Team Network, which is very famous in that area, and he is a clinical lead of their amputation root causes analysis. He has developed a personal affection for rectifying the inequalities in the care of people living with diabetes, passionate about improving care of people living with diabetes and food care complications. In his role as a Diabetes UK clinical champion, Chris led and development and improved access to diabetic food surgical procedure approach that has become even more critical during COVID time. This aims to deliver prompt one-stop assessment and day-care surgical procedure within a clinical setting to improve on waiting list, avoid hospital admission, and obviously decrease hospital stay admission. So we are extremely honored and privileged to welcome our second speaker, Dr. Chris Manu, for this Global Meat Awareness Week. Today's topic is a global analysis of the cost effectiveness of TLC. Welcome, Chris. So can we have his video? He's around, so we can have a question answers as well.
Good day, and many thanks to the D-Food International and for the opportunities for presenting this on behalf of the Ergo Medical, looking at a global analysis of the cost effectiveness of TLC-NOSF. I think I'll probably be preaching to the converted, or if I say that the DFU is a massive and growing global burden. It's a burden not just to developing countries, but it's already a burden on the developed countries as well, even where it might be assumed that there are good resources for this. On a global expenditure, diabetes is expected to have a global expenditure of nearly or over 900 billion. Looking at the contribution from DFU alone, in the US is estimated to be around 38 million, in Canada 38 billion, sorry, and in Canada 546 million, and it's nearly double that for the UK, and in a similar way nearly 600 million in France. But I think despite all this investment or financial burden, diabetes, as we all know, will continue to increase as per the IDF atlas and data that is available. And 1 in 4 of people with diabetes will potentially develop a foot ulcer. The worrying fact is that most of these DFUs will get infected and can result in amputation. And evidently there's over 1 million amputations worldwide per year, and as it usually gets quoted repeatedly, that 85% of these amputations are preventable. And indeed, we all know every 20 seconds someone somewhere around the world is having an amputation due to diabetes complication. So not only is this a morbidity burden, but also a significant mortality or significant impact on life, with the 5-year mortality rate being up to 70%. Mortality rate which we all know is higher than most cancers. So here we go, what can be done? The objective will therefore be to try and reduce the healing time. So the sooner the wounds can be closed, we can then perhaps avoid infection and amputation, and it's only by closing these wounds sooner can we maybe avoid this burden. In 2018, the publication of the Explorer RCT was a significant milestone, i.e. being the first study of its kind to be published in a well-reputable journal, the Lancet of Diabetes and Endocrinology. And as some of you might know, this was a randomized, it's double-blinded, and a double-blinded controlled, and it was stratified in 2 parallel groups with 240 patients, and these were done in centers across Europe, which were international renowned centers of excellence for looking after diabetes, patients with diabetes, foot ulceration. So of the 2 groups, both of them receiving standard of care, the active group having the TLC-NOSF and the control group having the neutral dressing, and in subsequent slides, treatment group depicted in red and the control group in gray. And these looked at the complete ulcer healing at 20 weeks follow-up. And indeed, in the treatment in the TLC-NOSF group, there was 48% healing and 30% in the control group, giving nearly 60% more patients were healed. And as I already said, this was a stratified trial. So looking at patients' outcome based on the wound duration at treatment initiation, the data also shows that the earlier the treatment was initiated, the percentage ulcer healing was much higher. On average, the mean ulcer duration for these cohorts was nearly 6 to 7 months. So these were difficult to heal wounds and chronic wounds. But looking at the stratification, the earlier the treatment was started, the better the outcome. So in summary, from the Explorer study, treating with the TLC-NOSF always delivered a better healing outcome, irrespective of time when it was started. But the sooner the treatment is started, or the sooner the treatment was initiated, the higher the efficacy. Subsequently, since the publication of the study, there has been a few health economic models that has been based around these results. And what I'll try and do in the next few minutes is to look at 5 of the published models in UK, France, Germany, China, and Canada. But there have been other publications as well, so an abstract in value in health, and 2 other projects in Czech Republic, Australia, and Spain, which these have all been done unilaterally or independent of the of Ergo Medical. It's been mainly clinician led. So starting with the UK UK results, or the UK model, all the models were based on the Murkoff model. In the UK, it looked at the direct cost, and then we used the perspective, or the outcomes as depicted or shown from the National Diabetes Foot Care Audit, which all centres in the UK that are, or in England and Wales, that are looking after patients with foot disease are supposed to report to. In this Murkoff study, the outcomes from the Explorer study was extrapolated to show what will possibly happen over a 1-year period, i.e. patients' proportions are depicted depending on different states, i.e. having an open wound pre-amputation, or closed pre-amputation, or healing with an amputation, and each time the proportion can be deceased or die accordingly. Looking at the results from the UK study, having treatment with the TLC-NOSF provided a better quality adjusted life years, more than the neutral group, and the spending per patient per year, i.e. in the TLC-NOSF, was cheaper to treat with the TLC-NOSF, giving between 300 and 400 per savings per patient per year. As such, the use of the ErgoStart range gave better healing outcomes and saves on treatment costs, reducing the healing time and better quality of life. Looking at the France model, again based on the statutory health insurance in France and the Murkoff model, this data was extrapolated to show a 1 year, 5 year, and 40 years. As such, it was trying to look at the entire lifespan of the patients, as in they can have ulcer, recurrence of ulcer, or healing and remaining healed. And this was done in 2 scenarios, looking at the ulcers as based on the Explorer study, or looking at the time of initiation of the treatment. And likewise, there was significant savings per patient per year, generated with the TLC-NOSF, and looking at all the wounds, there could be a savings of about £3,000. But once again, the sooner the treatment is started, the better the generated savings per patient. And again, it delivers a better quals gained. Most of the expenditure here comes from the hospitalization of patients and nursing care. As such, as we said from the beginning, closing the wounds sooner is what delivers the cost savings. Looking at the German model, again here it was extrapolated to 100 weeks. Again, looking at the two scenarios similar to what was done in France. And here, once again, for all the wounds, it was 30% cheaper treating with the TLC-NOSF compared to the neutral dressing. And again, the sooner the treatment is initiated, that generated 43% more or 73% reduction in cost. So again, the sooner the treatment is started, the better the cost savings that can be made. Looking at the China model, this was done for both direct costs and indirect costs, and done for Merkov model across eight states in China, and the time duration to wound closure at 20 weeks was extrapolated to 20 weeks. Once again, the same was true for China, and better quality of life gained. And again, the cost per patient, it was cheaper, about 1,400 euros cheaper with treating with the TLC and OSF. Looking at the Canada model was similar to the German model, in the sense that this was an extrapolation to 100 weeks of the patient's treatment as well. And again, a better quality of life gained. The cost per patient, again, cheaper, more than 4,000 euros savings per patient if treatment done by the TLC and OSF. So in general, treating with the TLC and OSF was definitely a less expensive. So it's less expensive and more effective. Going from the left to the right is more effective. So in economic terms, it is a dominant strategy, regardless of the country that the treatment is adopted or implemented, regardless of the health model or the reimbursement model of the country. So in conclusion, the evidence supports the case for adopting ergostat dressing to treat DFU, and although not presented here, similarly for the venous leg ulcers, as per the data or the conclusion from the UK NHS or NICE. And if 25% of people are having the treatment of their DFU with the ergostat instead of non-interactive dressing, then the NHS stands to save up to 5.4 billion each year. And as we said, this is all time dependent or time critical. And as I said from the beginning, in the Explorer RCT, TLC and OSF dressing have proven to reduce healing time, healing more wounds compared to neutral dressing. And if we're going to try and reduce this cost burden, I think it's about implementing this and early. And on top of the healing outcomes that the Explorer depicts, the 5 cost-effective models in France, UK, Germany, China, and Canada have demonstrated that using it is more cost-effective treatment option compared to neutral dressing, and it does deliver gains in years of ulcer-free life, and the sooner the treatment is initiated, the better the outcomes in terms of clinical benefits for the patient, and in terms of the savings generated by the health system, again irrespective of the country or the type of reimbursement system. And as such, the NICE guidelines has recommended the use of the ergostat as a first-line treatment, both for leg ulcers and for diabetic foot ulcer patients. Thank you.
Thank you very much, Chris. It was clear. It's open for discussion. Can you unmute you, Chris? I would start asking you that I know all this has been done in the Western high to middle income countries, and neuroischemia would be more. So do you think the treatment is only indicated for neuroischemic ulcers, or it can be used with other risk factors? That's number one. Number two is, should be only applied on non-infective ulcers? Number three, why it is, because you come from the same background like us, low middle income country, and our ulcers, whenever they present, they are infected. So it should be only applied to non-infected wounds. And number three, if the effective and cost is very good and healing rate is more compared to other, then why it is not broadly regularly used in the clinic? Then I have two more questions have come, but let's continue first with this.
All right. It's heavily loaded. Thanks, Prof. I think time and time again, from my understanding of maybe working on the clinical side, I think doing these studies, you have to try and standardize the patients who are recruited into it. So I think it's become a bit stuck by calling it the neuroischemic ulcers. But I think it was a way of trying to standardize the patients who were recruited into the study. And by and large, those were the wounds that were, I'll say, most difficult to heal. And trying to standardize the recruitment, I think that label has become stuck. And I usually say there's hardly any diabetic foot wound that is not neuropathic or having a degree of ischemia. So I think that label has become stuck because of the RCT. But I think in general, it can be put on any wound. It does not have to be just the neuroischemic wound. I think it was due to how the study was done. And indeed, I think there has been lots of cases or evaluations done to that aspect. So I think in general, from clinical point of view, I don't think it has to be stuck to just neuroischemic wounds. I think you mentioned something about infection. Again, during the course of the study, nearly 20 or 30% of the patients did develop infections. So again, it's about trying to standardize it. And most wounds will have colonization, but I think that got stuck a bit more because of the frequency of the dressing change. I think sometimes you've got dressings that have got a degree of infection needing daily dressing change with exudate, then certainly it doesn't allow the interaction of the dressing with the wound bed. And I think it was also to try and stop people from putting it on like osteomyelitis or not getting the infection under control. So I think by and large, it's about having an infection that is under control, that perhaps the dressing maybe needs to be changed 2 to 3 times a week to that level of frequency. But it was just to make sure that people were addressing the standard of care, making sure infection is under control, and then using this on top of that. So I think that is also something that has become stuck because that was what was done in the study. So I don't think it should be just stuck to those alone, per se.
And number 3, why it is not used broadly?
I think when I can speak a bit more perhaps in the UK or England, I think it's been getting close to nearly 10 years since the Explorer study. And I think it was more people working in the secondary care or big institutions seem to be aware of it. Whereas I think the nurses, people in the community, the GP, people who are seeing the patient first are not as aware of it as perhaps the people in this audience who are the food experts. And by and large, I think the patients get to us, our specialist clinics, too late. Like in this study, there were on average 7 months old ulcers that were coming in. So I think people are still getting to us specialists too late. And the first responders, so to say, or the physicians, the nurses who are seeing this patient first, perhaps still lack the knowledge to use it early. I feel, yeah.
There is a question has come that what is TLC-NOSF treatment exactly?
You then really, really, what is it? Test my scientific sort of knowledge. But I'm not an expert to be able to go into the details or integrity of it, but it's the nano oligosaccharide factor, or what is a sucrose octalphate sulfate. The main bit from my understanding, that reading back on this before, is how it's sort of inhibits the MMPs or things in the wound that try and shift the wound from a chronic state to an acute state per se. That's how the non-oligosaccharide or sucrose octasulfate works. With regards to the TLC, it's more to do with a lipid. I think it's a lipid colloid that is in the dressing that stops it from adhering to the wound surface. So there's two aspects of it. One of it is believed to act on the MMPs and trying to move wounds from the chronic state to the acute state. And then the TLC, people usually call it tender loving care, but it's more, it's a lipid colloid that helps for the wound not to be as adhesive to wounds. That's my diabetologist understanding of it, but I'm sure there'll be much more experienced people in the audience.
Yeah, thank you. I think there's another one on the chat box. What is the limit to use in ischemic patient, this product?
I think, again, just talking from my own clinical experience of using it, and even in the studies, it wasn't put on necrotic wounds. So any wounds, it's neuroischemic, but not on any necrotic wounds. It has to be in contact with the wound bed or granulating tissue. So if I understand it correctly, I think those sort of ischemic wounds need to be revascularized and debrided so that the treatment can be in contact with the wound base.
Yeah.
There's another one. How does it work in neuroischemic ulcers? Any experience in temperate, humid climate?
In what humid it says, is it?
Yeah, temperate, humid climate. The ulcer is neuroischemic.
Again, maybe someone from the industry may understand this better but in terms of the neuroischemia, there is certainly an element that it does something with regards to angiogenesis. I mean, I do like peripheral vascular disease. That's what my little bit of interest in this was. But there is certainly something to do with angiogenesis in case of its modality of work, although that was not how the dressing or treatment was marketed. And some studies have shown that people being on it, actually, the TCPO2 improves, not just from the wound healing or infection getting better with transcutaneous oxygen improving. So there is certainly a certain element of having angiogenesis with the treatment, although, I mean, the studies are being done about it. So in terms of the neuroischemic wounds, I think there is that element. with regards to its use in other climates, I'm not quite an expert, or I've not had any clinical experience of using it in humid countries. Perhaps others may be better placed to comment.
Okay, thank you. Anybody from the panelist? Yes,
Yeah.
Dr. Shakar, Professor Shakar, yeah.
Thank you, Professor, for your very nice lecture, actually. But I wonder, we are in Egypt or maybe in Africa. We have a great effort for all diabetic foot ulcers to find out the etiological factor for this ulcer, which made it persistent, which prevent the normal, natural healing, because they are well-known 5 main factors that we have to detect, and usually at least they are 3. And so we keep in mind this to find that. After we solve this problem, the wound healing is very smooth with saline. We didn't think about the dressing. When we thought about the dressing only, always, we have a massive limb loss. This is number 1. Number 2, the TLC-NOF, I didn't recognize what it is. And I think everybody, because you are from England and London, he will be ashamed to ask about that. But I asked it. I don't know what is this type of dressing, how it works. Why? Did you finish all the etiological factors, then you will put this dressing? I think if you finish all the etiological factors, the healing will be spontaneous. Thank you very much.
May I respond to a bit on that?
Yes, Chris.
One thing that I found interesting when this study was done, I think there must have been 6 or 7 centers across Europe. And the recruitment, so these were all patients who were being cared for in centers of excellence. And they were receiving the top standard of care that we can hope for all of these patients. And they were addressing all the standard of care. And one thing that makes it interesting is that these patients still had wounds that had gone 6 months and they were still not healing. And those that were recruited into the study, they even had a running period of where if they reduced by more than 30% over the first 2 weeks, they are not recruited. So I think there is still something there that even within our expert centers addressing offloading, revascularization, treating infection, there are still lots and lots of chronic wounds that are going more than 6 months unresolved in centers of excellence. So I think there is still a place for it. There are some wounds that, yes, we can heal, but for wounds to be going for 6 months plus in centers of excellence, I think there must be a place for something extra on top of standard of care. And but I agree with you, it is not a dressing that does the magic. We still need to address the standard of care, and this just comes on top of standard of care.
Thank you very much, sir. Thank you very much. But when you do the excellent care and 7 months is no healing, there must be something missing in the etiology, in the etiological factors. There must be. And thank you very much. I'm sorry to disturb you again.
Thank you. Yes, Linda, your hand is up. Yeah.
Okay, thank you very much, Chris, for this very important lecture, and also the emphasis on the cost-benefit models. I think this is a very important issue that is addressed, especially for us who live in low and middle income countries. Brazil is a middle income country, but it has a very diverse reality depending on the region that we are. Urgo has launched the name here is the Urgo Stat only in Brazil and Chile, as far as I know. I don't think it has reached other countries in SACA. And I think one thing that would be very important as you are speaking on this product is really to learn about the standard of care, because in many centers, even excellent centers that here we cannot call pure excellent centers because of the, in some areas, lack of resources. I think it would be very, very important to make this awareness about the standard of care and also call the attention to the offloading, because we all know this maximum or emblematic phrase that it's not what you put, but what you take off that really helps healing. So I think this is something very important. The company has done a lot in education in our region, but I think more needs to be done. And I think this very important points that you just showed to us are also important, especially for the policymakers.
Thank you, Linda. I think. Yes, friend, your hand is up next.
Yes, thank you. And it's really just to emphasize that in the trial, all the patients did have good standard of care before the dressing was applied. So they all went through standardized offloading for 2 weeks. And so many of them didn't actually get treated. So there was a group of people who were healed anyway, just to reassure you, and were always going to heal. So they were only ran anyway, but they just healed faster with the sucrose octasulfate dressing. And that makes a massive difference in terms of the cost effectiveness analysis, because most of the cost of foot ulcer care is actually in the regular attendance and the dressings. So that actually was the main impact. In terms of severe ischemia so there was a question there about the limit of use of ischemia. We've only got the trial data to go on, and they were neuroischemic. So in the trial, they had to have an ABPI of less than 9, but a toe pressure of more than 50 millimeters of mercury. So that might help you. And I think, the question about why not everybody uses it is exactly as Linda says, the company hasn't launched it in every country in the world. So it's not available across the world. But where it is available, it is used. And it is, in guidelines. So it is one of the few dressings that were actually approved in the International Working Group guidelines. But it is emphasized in that it is in addition to good standard of care, and where good standard of care alone has not resulted in adequate speed of healing. Good standard of care, as you say, Linda, requires good offloading.
Yeah, sure.
Chris, you want to comment? We have 2 more hands if you want to comment before we go to that.
No.
Okay.
Yeah.
Thank you.
Nothing to add. Excellent. Okay.
Yeah. Milind, your hand is up. Yeah.
Yeah. Thank you. And good evening to everybody. TLC-NOSF, it appears that this product is also there on the International Working Group guidelines with moderate evidence and moderate recommendations. Now, with such a guidelines, I would like the company to come out with the evidence is what is the mechanism in which this product works on the ischemic ulcer, and at what stage. Are you going to use this in all ischemic ulcers, or is there a criteria where you can use it, and how does it act? How does it increase the angiogenesis? Because we have fair evidence in hyperbaric oxygen and other oxygen which do not come in the guidelines, and there is an evidence that they create angiogenesis with a mechanism. So in such dressings, if they can come out with a mechanism by which it helps the angiogenesis and helps the ischemic ulcers, it would be a good information to all the centers in the world where diabetic foot is taken care of. India being the diabetic capital of the world, these dressings, if they are available on the insurance panel and in government setups, because 2/3 of diabetic patients in African sub-Saharan and India, Southeast Asia, they are treated in government hospitals. If these dressings are not going to be available at that level, how do we say that they are absolutely cost effective and helping to heal all the diabetic ulcers all over the world? I think there has to be a more evidence, there should be more information which should be given to the primary or secondary care centers, so this product can be used in a very wide way. So that is my appeal to the company and even our association to pass on this message.
Prof. Abbas, may I comment on
Yeah.
that quickly before I
Yeah.
go? Before maybe I leave the audience astray, and maybe apologies for using the word angiogenesis, and I need to take that back. But probably Prof. Frangen might back me on that. What has been put out there is really inhibition of MMPs, which are things that put the wound in a chronic state. So that is how the mode of action is. And by that doing, it speeds up the healing time. The reason why I mentioned the possibility of angiogenesis there is more speculative, not documented, that there seems to be something happening to patients' blood flow. But what is evidented from tissue sampling, histologies, and so on that has been studied is inhibition of MMPs, which is quite well documented for sucrose octosulfate as its mode of action. So I just wanted to say that that is mainly how it works, and that has been clearly well sort of defined in the literature. I just wanted to make that note so that I don't digress the discussion towards angiogenesis and say something that is not correct out there. It's inhibition of MMPs.
Yeah, just related to that, there's something in the box, and then we go to other hands up. It's from Barbados, Simon. He said, I have used 2 oxygen therapy in Barbados with extreme good results for a patient who has a plantar ischemic ulcer.
Like Fran mentioned, to recruit people into this study, yes, the ABPI has to be less than 0.9, but the toe pressures has to be more than 50. It was a group that they've got PAD, but this is not to replace revascularization. It's not to replace people who have got critical limb ischemia that needs angioplasty. This is not a treatment for that. But you had to have a criteria for difficult to heal wounds. As such, that was why that definition was made. So by no means is this a replacement or a substitute for people that, according to guidance, needs revascularization.
Okay. Yes, Jamil, your turn.
Yes, thank you. Talking about, again, the TLC-NOSF, I attended many lectures in Europe talking about this dressing, and even I visited Urgo stands. There is always something that is not clear about the mechanism of action, knowing that it decreases MPs from the wound bed matrix, as you just said. However, one thing is that this dressing, once it is applied, it should stay in place 3 to 7 days, correct? Okay, so...
Yes, correct, yes.
Okay, so in such cases, I am touching back to the question of Dr. Abbas. And in cases of infected wounds, wounds that are not contaminated or colonized, all diabetic wounds are colonized. Talking about infected diabetic wounds, can we stay 4 to 7 days without changing the dressing if we are using TLC-NOSF? This is question number one. And question number two, that was never answered on Urgo Stand's booth, wherever I go in the lectures, is about the monthly cost of this treatment. It's always, and there's always an escape from answering. We say in each country it is difficult and they don't give a number. So talking about France, talking about UK, if we are using every 5 days, this means 6 dressings per month. What is the cost of 6 dressings per month? And to recall the Dr. Abbas question, during these studies, were infected diabetic cases excluded or included in the large studies? And how can this dressing inhibit the multiplying bacteria? Is it safe to leave it in infected cases 4 to 7 days? So 2 questions, the duration and in cases of infection and the cost per month.
Okay. So to start off with, I mean, the indication of people who were recruited into studies was for non-infected wounds. So that was the definition, that it has to be put on non-infected wounds. And it was partly clearly because of that. And again, I'm a clinician, by the way. I'm not from industry. I'm just talking from my clinical experience of using it. So I might not be able to answer it all. But from my clinical experience as well, wounds that are infected with exudate, so not osteomyelitis or things that need, if infection with increased exudate that needs daily dressing change, then definitely no. So it's not for infected wounds. Okay. Within the study, there were still about 20% of patients who had infection. And in those cases, they moved on to silver dressing during the time of infection, and then they went back to TLC-NOSF. So, and even in the studies, the dressings were changed, I think, 2 to 3 times a week. So at that level of frequency, that was the same as you will do for most wounds if they are not acutely infected, needing daily dressing change with exudate, that they need changing 2 to 3 times a week. So in that sense, that was the frequency that was done in the trials as well. So I don't know if I answered your question. So it's for non-infected wounds. I agree, all wounds will be colonized, but provided the dressings are being changed 2 to 3 times a week, then that was deemed to be suitable. Or sometimes they go to a silver dressing and come back to it. With regards to the cost, I'm not hiding behind it. I'm a clinician like yourselves, and I honestly don't know the cost per week either. But it's not for infected wounds. I don't know if I answered a bit of the infected wounds or someone else can add on to that. It's more of a discussion, right?
Okay, so it is less expensive because we are doing less frequently application of this type of dressing. If we put 3 times per week, which means 12 times per month, this will increase the cost of the treatment. And I don't know if it will remain, it will stay cost effective and less costly than other treatments. But again, I need anybody in the audience and on the panel who is aware of the cost per month or per week. Nobody? There is a taboo inside.
No. I think people comment on that. And honestly, I don't know that. I don't think if anyone from the industry is here. But I think like Franz said, it's about doing it quickly or healing wounds quicker. So if you say per week, I don't know what the cost is, honestly. But if you are healing the wound 6 days sooner, I think it was that's where the saving is. Whereas if you continue to use neutral dressing, you can use those so-called cheap dressing, but for a longer. You treat it for 6 months. But if price for price, it may be more expensive, but you heal the wound quicker. And you save from the nursing visits, the clinic visits, and using a so-called cheap dressing, but you'll be treating the wound for 7 months before it heals. I think that is where the cost analysis sort of come from, rather than price for price.
Okay, so one dressing costs how much? Dressing?
I don't know, but someone else might say.
There's a friend is online. Franz, you talk, then Simon, and then Milan. Then we have to finish it. Yes, Franz.
I don't know the cost in every country either, but what I do know is that in the trial, when the dressings were changed 2 to 3 times a week, as Chris said, even though that dressing is much more expensive than a simple non-adherent gauze, it is still cost effective because of the time difference in healing. The ulcers were not clinically infected according to IDSA criteria at baseline. And sometimes that's a feature of trial design more than anything else, because you could end up with unequal groups. But the patients were not withdrawn if they became infected during the trial. And actually, it was up to the investigator at the local site to decide whether they continued the dressing. The investigator, and I was a site, and we continued the dressings. We were blind, so the dressings looked identical. So, half the group had the sucrose octasulfate dressing, the other half had a dressing that was identical. And we didn't know, and it was up to us. As long as you could change it 2 or 3 times a week, you could continue. And there were no more infections in the intervention group. And we didn't change the dressings in the trial, as long as we could maintain it 2 to 3 times a week. 3 times a week is every other day. So we would treat the infection with antibiotics and continue with the dressing. So we didn't necessarily change the dressing, and that was in the protocol. But they weren't infected at baseline. If they became clinically infected, it was up to the investigators, and we didn't withdraw ours. And just going back to something that Milind said actually about oxygen therapy in the International Working Group guidelines, actually hyperbaric and topical oxygen both had conditional recommendations in the IWGDF guidelines, just to be absolutely clear that sucrose octasulfate wasn't the only positive. So they were cautiously approved in those guidelines, but it's a completely different set of patients. As Chris said, this does not replace revascularization for people with severe ischemia.
Chris, you want to comment, or I go forward?
I don't know if
No?
you can hear me.
Yeah, we can hear you.
My screen has gone black for some reason. I cannot completely black, but no, nothing else to add. I agree with Frank.
Okay, we can see you and hear. Okay, Simon, you are next, then Milan, and then Harry will finish it. Yes, Simon. Unmute you.
Right, I just thought I would take the opportunity to just clarify what I was saying. Obviously, in the Caribbean, we don't really have easy access to vascular surgeons. We don't have very many across the region. So what I was trying to say was that with access to the oxygen therapy, I've successfully been able to use the oxygen therapy with standards of care to heal some of these wounds. And I guess maybe what I needed to add here was, one of the things that is very interesting is, as we look at the data, we always see the lower and middle income areas are the areas that are going to suffer the most with the burden of diabetes, the burden of amputations, the burden of ulcers. But yet the access to wound care products is not available. I have tried, it took me, I think, 6 weeks to get a VAC for a patient that desperately needed a VAC. And that was with me going through Canadian ways and US processes, etc. So I feel that these studies are amazing, but if we're really going to have to try to make an impact, we have to be able to make accessibility to reduce the length of time that these wounds are. We have the wounds. I agree with everything you said, Chris. Yes, the faster we can heal those wounds, it's better for the patients on many levels. It's better for the hospital. It's better for everyone. But the one thing that we knock our heads against all the time is access and cost. My hospital has betadine and gauze. My hospital uses a suction process through a wall instead of a VAC because of access to being able to access these wounds. So it's wonderful to have these studies, but I think we need to find a way of lobbying and trying to work together to build. I know every drug company is about making money. I understand we can't exist without money, but we have to find a way of being able to give the lower to middle income countries access to wound care products so that we can also improve our outcomes.
Okay. Yes, Milan, you wanted to ask something?
So, Chris, a very nice presentation and those randomized controlled trials that were conducted all over the Europe. So, I've used a lot of Orgostat in my country. My observation why I was asking you these questions was there has to be some alteration in the dressing material for the countries which are in Africa, temperate, humid climate. Because what I have observed as a surgeon is when you put this dressing on the wound, on a clean wound, the surrounding skin starts macerating. Whether this dressing was made with in Europe and to that climatic conditions, and should it be modified for the other climatic conditions is my thinking. I think that can be passed on to the company. I think it can have a better effect, and those RCTs would then can be tried in other areas of, and we can, as Simon said, we can all together work towards the
So you can go to Asia, Africa, and Caribbean. Okay. Yes, Professor Shakavi, short question because we are running out of time. And then I give to Harry and he can finish it. Yes, Professor Shakavi, yeah.
Me? Okay.
I
Thank
see
you.
your hand is up.
Yes. Thank you. The point is, all diabetic foot ulcer usually at least potentially infected. No pure, very clean ulcer in the foot. The foot is near the ground, near the dust, near the dirt, always potentially infected. And I'm sorry to say that the dressing have never been a tool for limb saving to avoid amputation. Amputation or limb saving have another protocol, and this is adjuvant. If you do the proper way, center of excellence, healing will be spontaneous with saline. I think that in my country. Thank you.
Yes, I agree with you. Yeah, that's what I do, yeah. Okay, so we have to finish this. Harry, you ask question and then as a tradition, President-elect gives vote of thanks.
Thanks, Abbas. I think just to add here, basically, I think when you look at the Explorer trial, they were looking at ischemia 0.8 to 0.5, not critical limb ischemia itself. And it was added to standard of care. That means what standard of care is already there in one arm, we added it to the other arm, basically. And one of the things is there is a particular paper on the molecular mechanism of action of sucralfate in epidermal and dermal wound healing. And the actual effect is actually the binding of the sucralfate to the FGF and EGF is the one which actually results in the maintenance of mucosal vascular integrity. And this actually increases the blood flow. So that's how it facilitates angiogenesis itself. That paper is actually a very new paper, which was actually sent to me by Serge Bobo this year, because I did some of the work on systematic reviews on basically Ergostat itself. And just to add to Milan's question there, I think you're using the Ergostat, which is the contact layer. The contact layer is like a tool dressing per se, so that doesn't absorb anything. So the other one that Chris mentioned is basically the tender lipidocolloid with the NOSF. That one is together with the foam. So the foam will actually be used better in that sense, where you have got the Ergostat there, but it's also backed up with a foam which can absorb and prevent your maceration itself. I think that should actually add up to what we have already mentioned. Now, I think due to time, and as Abbas has asked me to finish, I would like to take this opportunity to thank our two wonderful speakers, Professor Andrew Boulton and Dr. Chris Manu, for spending time over for our global meet actually during this 1 week of the Diabetic Foot Awareness Week. And then I would like to thank Abbas and the board, the regional chairs and members, all who are here from all the different regions, the 7 regions under DFU International, and also the members and the delegates who have come, and Ergo, who has been funding us as a very great supporter, Ergo Foundation, and then Zaima, who's actually with DFU International and helped supporting us. I think all of you did a wonderful job. It has been a superb session. And like what Milin has mentioned, it's always great to see all of you all basically online or physical, even better, as we all form the family against the preventable amputation of diabetic foot patients itself. So with that, thank you. Have a good week.
Thank you very much. Just last 7th December 2024, Saturday, 2 p.m. There is a webinar by Professor Denwick on surgical aspects of diabetic foot ulcers. And I already see here 3-4 surgeons, so don't miss it. Mark from now. 7th December, Saturday, 2 p.m. Central European Time. Okay? Thank you very much and wish you all the best. Thank you.